Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. One way Medicare Advantage plans attract enrollees is by providing supplemental benefits such as dental, vision, and hearing care beyond what's covered in traditional Medicare. These benefits may be particularly attractive to lower-income individuals who'd otherwise face sometimes insurmountable financial barriers to receiving this essential care. So, do supplemental dental, vision, and hearing benefits close the access gaps for enrollees in Medicare Advantage plans? That's the topic of today's episode of A Health Podyssey. I'm here with Avni Gupta, a researcher at the Commonwealth Fund. Dr. Gupta and co-authors published a paper in the October 2024 issue of Health Affairs that looked at the relationship between Medicare Advantage benefits, plan star ratings, and enrollees' access to dental, vision, and hearing care. We'll discuss what they found in today's episode. Dr. Gupta, welcome to the program.
Thank you, Alan. Thank you for having me.
Thank you for joining me today. Before we get into the specific findings of your paper, I wonder if you could just set the stage a bit with what we know about financial barriers to access for the key services you studied, dental, vision, and hearing, among the older population just in general.
Sure. Yeah, so what we knew about financial barriers in general among older adults is some of the previous research work which has used survey data, has identified that nearly 16% of older adults, that is around 10 million individuals, report not getting needed dental, vision, and hearing services. And more than 70% of those report that is because of the cost, that they are not able to get these services. And I think it is also important to appreciate the prevalence of these conditions. Nearly 9 in 10 older adults have had a decay. 1 in 6 have untreated decay. 2 in 3 have gum diseases. And nearly half report vision and hearing difficulties. So I think for conditions that are so prevalent in older adults, having these unmet needs due to cost can lead to significant health issues.
You know, it reminds me how long it took to get a drug benefit in Medicare, and here we are with a very high need population around these services, and they aren't covered in traditional Medicare. So one way to entice people to join a Medicare Advantage plan is to say, we'll cover these supplemental benefits. What can you tell me about whether or not the Medicare Advantage plans that people are offered tend to include these kinds of services as supplemental benefits?
It's very popular. These dental, vision, and hearing benefits are traditionally the most commonly offered supplemental benefits. And in the last few years, more than 90% of the plans, and I think in 2020, the most recent data, 2024, more than 95% of Medicare Advantage plans offer one of these benefits. And much higher, 98% of MA beneficiaries are enrolled in plans that offer each of these benefits. So yes, you're right, Ellen. These benefits are really popular tools for Medicare Advantage plans, maybe to attract beneficiaries.
Yeah, so this is, I think, a great way to understand the context for your research. We have a high need population with significant amounts of access barriers, particularly financial access barriers. Plans have figured this out. They want enrollees, and so they offer this benefit. And that is, we're not looking inside the heads of the enrollees, but presumably the fact that they're so common and that almost everyone who's in an MA plan has these benefits would suggest that it's a factor in people choosing the plans. So let's turn now to the work you did in this study. You used population survey data to estimate unmet need for these services among MA enrollees. Let's start just sort of getting a picture of what you found. What did you find about unmet need, and what dimensions did you look at, particularly around income, which is the dimension of the access barrier you focused on? What did you find about the role of income in having these barriers?
So, starting from where you started, Ellen, that supplemental benefits are are really popular, especially among low-income individuals. And the reason is because these benefits are mostly funded by rebate dollars, which for people who don't live and breathe Medicare Advantage, rebate dollars are paid by CMS to Medicare Advantage plans. And they're used by MA plans. One of the ways they're used is to provide these extra benefits. The reason I mention that is because that means that these benefits often come at no or very low extra cost to beneficiaries themselves. And hence, people who have fewer resources, low-income individuals, they are naturally attracted to having these extra benefits at no extra cost. So what we looked at was that, well, low-income enrollees may be getting attracted to MA plans for these benefits. Now, does it make a difference in their access for these services? And what we found was not really. We found that low-income enrollees are twice as likely to report unmet needs due to cost as compared to higher income enrollees. And I want to remind listeners that we looked among people who are enrolled in a plan in one of these, in each of these benefits, actually. So this is after you choose a plan with a dental benefit, there are still income differences in your ability to access these services. And we adjusted for several different measures of benefit generosity and we found a similar pattern of low-income enrollees being less likely to be able to afford these services, even though they might be getting attracted to plans with these benefits.
So I'm glad you took us to the rebate issue. We'll go a little deeper later in the discussion about sort of what the policy directions are coming out of this. But I just want to make sure I understand here. You're, first of all, in your paper, low income is below twice the federal poverty level. So this is people with quite limited resources. So what you're describing to me is that people enroll in these plans that have a benefit, but even when they do, they still face financial barriers to access. And those barriers are much higher for low-income people than they are for higher-income people. I guess the first question I would ask, because we always know poorer people are going to have challenges, is, does everyone's access improve a lot? It's just not quite enough for the low income, or does it really just not make that big a difference whether or not you have these benefits?
No, so it does make a difference. This was not the goal of this study, but we have seen over and over again that having insurance, having coverage does make a difference in access. So that was not the goal of this study. That is not what we looked at in this study. But yes, it does make a difference. I think what is critical here is that Medicare Advantage plans get paid on a per enrollee basis. And since there is no standardization of supplemental benefits, just by offering any level of a benefit, they can attract people and still get those per enrollee payments. And there is no check or quality control on whether it leads to improved access. And I think that is why the income differences are really significant, not statistically, but like clinically and meaningfully, policy perspective, it's important in Medicare Advantage context.
Okay, so what I'm hearing is that plans can use these benefits to attract enrollees, but there's no standardization of the benefit, and there's no quality metric around the benefit. And what we're seeing is persistent income differences, even among enrollees with these benefits, which would suggest that they're not closing the access gaps for these services. Is that right?
Yeah, and there can be many ways why access barriers can exist. One is outright no coverage, but then we adjusted for several coverage measures in our study. But we have to understand that particularly for dental, vision, and hearing benefits, the variation in generosity can be extreme. Like plan can limit what they pay maximum for a person, like $1,000 in a year, how many visits they're allowed. how many x-rays they're allowed, how many eyeglasses they're allowed. And these variations are really hard to adjust for in a survey sample. And that is where, standardization comes in. Plans are not required to provide any of these benefits. And if they can provide any level of these benefits. And they can create any level of variations in all of these dimensions: provider network and, referral patterns, prior authorization requirements. And these details are very hard, even for very health literate people, to understand. So when it comes to people who are high needs and low resourced, it is very difficult without any standardization of benefits to expect that plans on their own will provide benefits that will provide meaningful access. And I think that's how, or that's why we think that it is important for people to understand that just seeing a checkbox for dental, vision, and hearing is not it. It is not like standard Part A and B benefits. These can vary hugely across plans.
Okay, so I think we've really hit a core topic here, which is that labeling the benefits as dental, vision, and hearing leaves a lot to the imagination about what they really are. I want to talk to you more about the quality and access dimensions, the standardization topic that you've just raised. We'll cover those topics after we take a short break. And we're back. I'm speaking with Dr. Avni Gupta about the unmet dental, vision, and hearing needs of low-income Medicare Advantage beneficiaries. In the conversation thus far, it's really become quite clear that even though people are signing up for plans that say they have these benefits, they continue to face access barriers, and those access barriers are much higher, double, for people who are lower income than those who are higher income. So we started before the break talking about sort of standardization and how people make their choices. One dimension of choice that people can use when selecting an MA plan is the star rating system. And you introduced the topic of rebates before. We're not going to spend the whole time in this podcast talking about payment of Medicare Advantage plans, because that would get us down a road that we'd have a hard time coming back from. But could you say a little bit about what the star ratings are there for, and whether or not that's a dimension that's helpful as we think about people gaining access to these supplemental services?
Yes, great question. So once we kind of found that low-income enrollees are not doing as well as high-income enrollees in terms of access to these services, the next question was that, well, maybe they're doing better in high-rated plans because high-rated plans receive higher rebate payments. Again, not going into the whole Medicare Advantage payment system, but the rebate payments to plans depend on a star rating. So the low-rated plans, 3 rating or below, receive lowest payments. High-rated plans, as we call them in our study, are 3.5 to 4 rating, and then highest-rated plans are 4.5 or 5 rating. So the payment changes with the star rating. So what we thought or hypothesized was that, well, maybe the highest-rated plans that have 4.5 or 5 or higher rating, because they receive higher payments, they might have better resources, financial capacity to be able to provide benefits that are more comprehensive, or better networks, or in other ways that they can improve access for their enrollees more than other plans that receive lower payments. So what we found was there was no such evidence or no such association between eligibility for higher payments and unmet needs. And why I'm saying eligibility for higher payments is because we looked at it indirectly. We looked at the previous year star rating, because that determines plan payments in the year when plans are deciding their benefits that they will provide to enrollees in the next year. So we looked at the previous year star rating and hypothesized that plans who were high or highest rated in previous year, they would be receiving higher payments this year, so they will have more financial resources or capacity to provide better benefits, hopefully, and that might translate into better access or lower income disparities for people. And we didn't find any such association. So I think that really raised a question that why are we paying quality bonuses to these high or highest rated plans? And without any quality metric system to kind of measure the performance of these plans on supplemental benefits, there is no way to assure that those billions of dollars, like 10 or 12 billion that in the last year, that's what we paid in quality bonuses, are actually trickling down to beneficiaries, leading to their improved access.
Well, so that's really the rub here. And again, it's hard to have this conversation without continually referring back to the payment system within Medicare Advantage. But you'd like to think that a high quality plan that's getting a bonus from the government because it's high quality, and then has the resources available through the rebates to provide more comprehensive benefits and says to its enrollees, here, come join us. We have dental, vision, and hearing, that they would have the resources and also not just the wherewithal, but the desire to provide a comprehensive benefit that would overcome the access barriers. But what you're saying is we don't see any evidence that that's happening.
No, we didn't see any such association for dental, vision, or hearing for high or highest rated. I was just going to add that I know this is moving away from our discussion about the payment hypothesis, but just so that we don't lose sight of the positive finding, is what we found was that if we look at the current year star rating, we did find that the cost-associated unmet need overall and income disparities in cost-associated unmet need only for dental services is better in highest-rated plans. So if I choose a plan this year in open enrollment that I say 5 rating, that might give me better access to these services or lower income disparities for dental services. But that's not the payment hypothesis that we were talking about.
So as we come to an end, I just sort of want to weave the threads together that you've put out here. And it goes back not just to the payment method, but the lack of standardization. So I think this is probably the place for us to bring all of these components together. Fundamentally, when people are faced with the opportunity to enroll in an MA plan, they're doing it on the basis of whatever information they have available to them. And one thing they'll see is notation that there are these supplemental benefits. They're very common, of dental, vision, and hearing, almost universal. But then, as you note, there are so many dimensions underneath the heading dental that have to do with levels of coverage and network adequacy and which services are included and excluded and all of those kinds of things. And you could tell a similar story with the others, that without any boundaries around how those are defined, we jump ahead and look at the data and find out that there's still huge income gaps in access based on financial need, even after all these benefits are offered. And so you suggest the need for some level of standardization. Presume that would help us with the research that you're trying to conduct, but it would also help enrollees pick a plan and figure out whether or not it's really going to meet their needs. So just as we finish this conversation, we started by noting that in some sense, it's odd that these aren't even in the base Medicare program because the levels of need are so high among this population. But assuming we're not yet at a place where they're going to be built into the core program, how would you suggest to policymakers that they think about what opportunities they have to at least give some more meaning to these in a way that reflects what enrollees are getting so that they can make an informed decision, and we can feel confident that those rebate dollars are actually closing access gaps.
Yeah, that's really the meat of the conversation. So I think CMS has already started taking steps in this direction. In the most recent rule that CMS proposed, CMS is beginning to collect data on supplemental benefits, and it has made clear to the MA plans that they were never excluded from the encounter data system reporting requirements. So I think that is a huge step in itself, because until now, we didn't even have data on the utilization of these benefits. Like, we were paying all these dollars to plans, go provide these benefits, but then we had no data on whether people are using it, whether people know that these benefits exist. So I think the first step is really having data on utilization of these benefits. And I think once we kind of set that system up, and it's going to take a lot of hiccups because of the different types of benefits and reporting requirements. But once we have that data, I think the next step is really to think about how to incorporate it into the star rating system or the quality rating system, maybe rate plans based on the quality of these benefits. We use several sources of data for the star rating system. It has more than 40 measures, and we collect data from different sources to kind of understand in general how the plan performs. So I think such kind of system for supplemental benefits would be beneficial for people to know. It's logistically, it can be really challenging because of the diversity of these benefits across plans. And I think that's where standardization comes in. Defining an essential health benefit kind of package for these benefits, what is meaningful and what plans must provide, if they are actually providing a benefit, would actually help to think about a quality metric system when we have defined a few things that plans should be providing, and these are some of the outcomes that we expect out of those services. People who need eyeglasses have them. They are getting eye care every year. They are getting dental visit every year. They have access to prosthesis they need, or the kind of specialist they need. So that can translate into a quality metric system. Hopefully, that's the aspiration, that's the hope of this research, that it leads to a system where we have data, we have standardized benefits, and a quality metric system for supplemental benefits. So people are not just attracted to these benefits, they actually get meaningful access from these benefits and better health.
Well, this makes a lot of sense to me. You know, we have examples of standardization. We have in Medigap, A through J, different plans. We have some of the Affordable Care Act exchanges, marketplaces have standardized. Of course, we have the tiers of silver, bronze, and gold, which are not precise in terms of defining the benefits, but are precise in terms of actuarial value. So there are ways to standardize that aren't too rigid. And then, as you mentioned, we have a significant quality enterprise out there that we apply to many things. And there's really no reason we couldn't extend the quality metric enterprise to these sorts of benefits and report back on plans. So I realize that getting from these ideas to making them happen is a long road, but I appreciate the insight that your research has provided in terms of what we are and are not achieving by having all of these benefits provided, and what's needed in order to feel more confident that these federal taxpayer dollars are actually going to help meet people's healthcare needs. It's a great and it's a great area for potential progress, and I appreciate the way you've laid out what it would take to get from here to there. So, Dr. Gupta, with thanks for the research and the explanation, I am so pleased you were my guest today on A Health Podyssey.
Thank you so much. I'm glad that this research will be out soon, and hopefully it makes a difference in how we think about policies in MA.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about A Health Podyssey.